We can go ahead and get started here. Thank you for helping me out and completing that. For those who haven't met me yet, my name is Jack. I'm a PGY 2 here, so it's great to see all these fresh faces. I know last week was a lot of news and a lot of fresh, so each week gets better, I promise. So today, we won't be discussing any incredibly intricate medical topic, but we will be talking about something that is super important. You will get a lot of different opinions on MDRs. For those that have been on floors and started last week, it's an interesting process where you go in for your first time. You're not really sure what to say. You're not really sure who's who. You're not really sure what the purpose is. And so today, I'm just going to kind of give us a crash course on MDRs. I promise you that once you get a feel for MDRs, they will make your life better. A lot of people will say it's a waste of time. Some people will say that it's something that comes and goes and nothing gets done. I promise you, if you use it kind of the way we talk about it today, it will make your life easier in the long run. You will look good in front of your seniors, in front of your attendings, and we'll all know have a good time. We can get started here. So introduction to MDRs. So I'm kind of just going to talk a little bit. We can read what's on the slide here, but I'll talk a little bit briefly about it. MDRs right now are scheduled at 10 o'clock. They're going to be on the 6th floor. So in between your rounds, you guys will go on up there and you're going to go from table to table and discuss with the team on that floor your patients. What is it good for? So MDRs itself is to focus on safe, timely, and efficient patient discharges. What does that mean? When we are specifically at this hospital and others, but we'll talk about this hospital while we're here, a lot of our patients require extra things that we don't really think about in med school. And these are all components that we need to line up prior to them being safe for medical discharge a few days in advance. And there are certain steps that we can take as we kind of go down that route. It is a team collaboration aspect. So we'll introduce each team member, kind of what they're good for, who to reach out for, and how to kind of close these loops of communication here. Impact of patient care, really important on discharge delays. Enhances safety and improves resident efficiency and teamwork. Basically, the smoother and faster we get at MDRs, the better you'll see end of all transitions for the patients out of the hospital. And then lastly, we can go into resident professional growth. So mastering MDRs early versus just waiting to kind of get good at it as the more you see it is going to help a lot in the long run. We can go on to the next slide here. So why MDRs matter. MDRs allow us to come together with everybody on those roles and understand what the patient is here for, why are they here, what's keeping them here, and what are we doing to get them ready for discharge. There's a lot of different factors that when you're a new resident, you don't really think about. And so you rely on your senior to kind of help guide us. If we can start thinking about these things now while balancing the medical side, I promise you it'll pay off in dividends down the road. Pretty much it comes down to enhancing this communication. So knowing what we're talking about with our teammates at, we can call them that, but knowing who to talk to at MDRs, PT, charge nurse, pharmacy, and then lastly, the case manager. And kind of go forward from there. All right, so I'll talk a little bit about the ready framework that we kind of came up with here, but what are we doing at MDRs itself? When I first showed up at MDRs, I gave a 7-minute long H&P, including their family history, their social history, whether they smoked or not. And the case manager looked at me and said, okay, are they going home today? And I said, no. She said, okay. And I walked away. So for MDRs, yeah, you can do that if you want to, but do not. For MDRs specifically, my strategy is when we're looking at our notes and we're looking at our patients, so you'll get to know the floors that each patient is on. And that kind of just takes time. But when you walk upstairs, you'll see that each team is going to be on a different floor. You're going to isolate your patients to those specific teams. I like to go up and we like to talk about why the patient is here. Are they medically cleared for discharge? And are there any pending items? You'll get a good feel for that the more we do it and the more we talk about it. We can talk about this framework here. So the first one is going to be roles, knowing each team member's role. It's really important, especially in medicine. It's such a team game. And I know that kind of sounds corny, but it is true. We do have a lot of different members who have different roles. It's really important to reach out to each of those members individually instead of just waiting for things to kind of happen. Any good attending will tell you that if you have a question, go ask. If you need to see somebody face to face, go do it. Because a lot of times Our case managers are so busy, our charge nurses are so busy, we're so busy, stuff can slip through the cracks really quickly. So it's really important to do things face-to-face. And in order to do things face-to-face, you need to know whose roles are what. So we'll talk about that. Evaluate, we're gonna identify discharge barriers early. We'll get to know what those are the more we're on floors, but if I can introduce them to you now, you'll kind of get a feel for what we're doing. And when we see patients in the morning, we'll be able to talk to our nurses about kind of weaning those down as needed and talking about transitioning to things that we'll talk about. Lastly here, and then we're going to move on to anticipate. Again, this kind of gets easier the more you're on floors. But when we are with our seniors, it's good to start thinking in this mindset of being proactive about balancing our patient. So we are managing from them from a medical aspect. That sometimes is the easy part, is managing them. We all know how to treat now, but you guys will learn. All know how to treat UTIs, all know how to treat community-acquired pneumonia. It's while we're managing them from a medical side that we are also working on the social side. So they're kind of two different parts of it. We're going to discuss. So communicate early during MDRs. Talk about updates, talk about foreseeable events that you can maybe think are going to be an issue down the road. And again, you'll get a good feel for it, but talk with your seniors early. Say, hey, could this potentially be a problem? Is this something that we need to think about? And then bring it up. It never hurts to bring it up during MDRs. Lastly, it's just going to be yield. So when we talk about things at MDRs, you'll walk up and I'll just give you an example. We'll say a patient has been here for a day or two. They recently got downgraded from the ICU. They're much more stable. They're going to need an extra facility to go to, but physical therapy hasn't seen them yet. And in order to get the specific recs from where they're going to go to, we need PT and OT to see them. I'll talk about it when we go over our checklist here. But our case manager, our charge nurse will say, hey, PT hasn't worked with them yet. We need an order in to see where they recommend them going to go. So you write that down in your note. The second we leave MDRs and you get next to a computer, place it and then move on. Again, it's just doing these things proactively that allow your list not to just pile up at the end after you guys are sleepy and we left noon conference and you're kind of dazed. You already have half this list checked off as we go. So these are thinking about things. I know as a more advanced intern, but the more and faster we think about it now, I think the better off we'll be. All right, perfect. Yeah, thank you. And then I'm going to pass off this framework here. So everybody just take 2 and then pass it on here. Thank you. So you'll see our ready framework here, which is what we talked about. So stands for roles, evaluate, anticipate, discuss, and yield. So we go through each of these letters here, and we'll talk a little bit more about each of them, okay? All right, so roles. This is a big one because you hear about these things in med school, but you don't really know exactly what they do and what they're here for. So being efficient on floors is knowing exactly why different staff are there and how can we use them to better influx patient care. So first one is going to be PT. PT assesses mobility, gait, and fall risk. We kind of all know that. But really the most important utility you'll get from a physical therapy note is where are they recommending a patient to go. This is our biggest thing. You can see this easily with the 33-year-old healthy female who has a safe home, came in with a UTI, we downgraded her, or we transitioned her out after a day, she's going to go home. But our more complicated patients are patients that might need a little bit of extra care. PT will work with them and they will recommend to you where that patient is going to go based off of their recommendation. They use different lingo that we'll talk about as we further get on. They also recommend DME, or durable medical equipment. These are things like walkers. These are things like bedside commodes. These are things like canes that we will place orders for that they will get upon discharge. OT is similar to PT, but think of OT as your ADLs. Think of OT as your activities of daily life. When I see patients and we're placing orders for therapy, I always do PT and OT. They will usually be congruent and where they're going to send the patient, but again, it's good to have. Also sitting at this MDR's desk is going to be case management. Case management are going to be our social workers. They're going to be our case managers. They kind of wear multiple hats. They are in charge of all the stuff we deal with here in the US, from insurance barriers to discharge locations. All the fun stuff you don't learn about in med school is like real world practicing medicine now. And so you'll get a good feel for it. Specifically, skilled nursing facility is SNF. IPR is inpatient rehab. Home with home healthcare, these are 3 different things that we'll go over when we go over our checklist about what they're helping place the patient in after they're medically cleared. navigates insurance authorization. We know all that. Coordinates DME delivery and kind of closes up all our loops. So a lot of times the case managers have multiple patients they're dealing with. A lot of our patient population requires extra care. Do not be afraid to epic chat them. I feel like, side note, that's one of the biggest things about early intern year is just feeling comfortable sending that text or making that call or reaching out to the attendings. And as soon as you can get over that hump, Joao texted a CT surgeon at 5 a.m. last week, and he will do it. And 6 months ago, you don't think about that stuff, but you reach out to people. We close loops. We're constantly talking to people about their recommendations. So it's important to get over that hump and just send that text, reach out to them. The more comfortable you get with that, I promise you the easier life will get. I didn't like it at the start. It's something that you get more comfortable with as you do. But as soon as you kind of dive off into that deep end, I promise you it'll pay off. Charge nurse, they will usually, when you walk onto the floor, they are usually sitting there at the top. If you need anything done for that day, you walk up and you say, hey, are you charged today? I'm Dr. Blank and Blank. I've got patient in 300. I am primary on this case. She didn't get her CT done yesterday. Can we please get it done today? The charge nurse looks at you and says, I will get it done. Instead of bogging down your nurse at 6 a.m. who's currently taking sign out and doing all these things, these are kind of the closed loop things that you learn as you get further into your intern year that I promise you speed up things along the way. So charge nurse is awesome. Knowing them early, knowing who to talk to, creating relationships early is super helpful. So that's kind of their thing. Lastly, we have pharmacy. I love our pharmacists. As a new intern, you will get paged constantly for placing in slightly wrong orders, and they'll reach out to you, usually in a nice way, about how to change it. So don't look at it as pharmacy's questioning me or they're giving me a hard time. Look at it as we're learning from them, because all their job is medicine, all their job is dosing, and there are a lot of intricacies when it comes to renally dosing medications, et cetera, et cetera. So our pharmacists are allies. Look at it like that. They're awesome. Anytime we need help transitioning from IV to PO medication, anytime we need to talk about how the dosages line up one-to-one, please use them. Please feel free to reach out to them. They are a really good resource. All right, so kind of moving down here into evaluate. So we'll go through it when we go through our checklist here. So right in front of you, if we move away our ready framework and we move into our checklist, we'll talk about it in the next few slides here. But we're looking at clinical readiness first. So first question we ask on that is the patient medically stable? I get it. We are super fresh interns. We are getting a feel for when patients are medically stable. Sometimes you'll be like, this patient is going to be here for a week. And your attending says, they can go home today. And you're like, oh, okay, sure, whatever. I get it. But they actually have it. You get a feel for it the longer you're in it. I get that. It's kind of figuring out what certain clues you put together to make us feel like this patient is more ready. So general things, stable vitals, improving labs. Their white count was 10 yesterday. It's 18 today. We're not going to send them home. It was 12 yesterday. It's down trending repeatedly. They're stable. Their sepsis has resolved. Their white count's resolved. We've got antibiotics that we're ready to transition. These are the things we're kind of lining up to make sure that they're ready to go. Oxygen needs. Side note, if a patient is a COPD, and you'll learn all this, but it's fun just to talk about it now. If a patient is COPD, if a patient has lung issues, and they come in on oxygen, the number one thing we ask is, are you on oxygen at home? Because if they're on oxygen at home, we can get them to their home O2 levels and then get them out of here. If they are not on oxygen at home, that requires further steps that we'll talk about in our checklist. But good things to think about as we kind of go through this line here. IV meds. A lot of times we will start patients on heavy IV antibiotics, right? And then we'll de-escalate and narrow as the patient improves and as we continue to get sensitivities back. Getting a feel for asking your senior or asking your attending on rounds, hey, are we ready to transition or do we need a few more days? Getting the feel for that and asking those questions early, I promise, pays off. Simple things like last week I had a patient with subdural hematoma. A lot of times the neurosurgeons love to prescribe IV Keppra. She was on IV Keppra. She'd been on IV Keppra for like 5 days. And my senior rolled in and said, can we transition her to PO? And I said, we can absolutely transition her to PO. I didn't even think about that. So it's small things to think about as you're going down, that the sooner the patient is accepting PO medications, the faster they'll be able to be cleared for discharge. Obviously, there's some like asterisks there. ID, infectious disease. If they require long-term IV antibiotics, that's something we talk about with them, okay? These are all things that You guys don't necessarily have to know now, but it's questions to bring up with our seniors and our attendings on rounds that will make life easier as we kind of go down the road. All right, functional status. Are they mobile at baseline? Are they independent with ADLs? You will be able to go through and look at all these on a PT and OT note and figure out what's next. We'll talk about it kind of the next steps here. Disposition needs, we'll talk about it. Basically, when a patient comes in and PT and OT evaluate them, they'll give you 3 different locations, I guess 4. They will be able to go home with no issues. If PT says home, we can kind of check that off the list as further needing anything else upon discharge. If PT says HHC, or more specifically, low intensity rehab, that is home with home healthcare. I think there's some legal stuff that I'm not going to ask about as to why they say low, moderate, and high intensity rehab. This is just a lingo we kind of get a feel for. Low intensity rehab is home with home healthcare. Looking further at that note, let's say they say moderate intensity rehab. That is lingo for SNF, or skilled nursing facility. We'll talk about it when we get to our checklist here, but skilled nursing facility means we need to talk with our case managers about placing them in that. Lastly, high intensity rehab is a very narrow patient population that is good candidates for high intensity rehab. We'll talk about how to order that when we're done here. We have our PM&R doctors. We have other teams of IPR doctors that will come in and take a look and evaluate the patient and to see if they'd be a good candidate, and then they'll go. High yield for you guys. Low intensity rehab is home with home healthcare. Moderate intensity rehab is skilled nursing facility. High intensity rehab is IPR, or inpatient rehab. Logistics and barriers, kind of talked about it. DME needs, they'll say to you on their note, hey, patient needs a front wheel walker. And you will then say, senior, how do I place an order for front wheel walker? And they'll walk you through it. It's very easy. Medications and follow-up, MedRec, that's kind of basic here. But outpatient follow-ups, again, we'll show you kind of all how to do that here. All right, lastly, we're getting towards the end of our ready framework here, anticipate and discuss. Proactive discharge planning. So anticipation involves early projection of discharge dates and initiating essential steps to avoid last-minute delays. If I can give one piece of advice, it's the sooner we look at physical therapy notes and know where the patient is going, institute those steps with the help of your senior, the faster, once a patient is medically stable, they will then leave and be able to go. The hospital is a great place to come and get stable and get healthy. But our patients that sit on the floor for days and days and days and days and days decompensate. And I know it seems like it's okay because they're on your list and they're a rock and they're not doing anything and they're stable until they go into AFib or they throw a clot or they fall and all this crazy stuff happens. So I promise you, the sooner we can get a good feel for patient is stable, how do we get them to a safe discharge location, A to B, the easier your life will be. I promise you that. Clear and focused communication. Again, I can't really overestimate or underestimate the importance of talking with other members of this team and feeling comfortable with just reaching out and send. We're lucky in this hospital that we have Epic Chat and we can just message anyone. It's crazy. Usually you have to call other people and get a hold of them that way, but you can Epic Chat pretty much anyone, anytime, and get an answer fairly quickly. Please make use of that because it really is helpful. The reverse side of that is that they can get a hold of you anywhere, anytime, and that's another story. But use it to your advantage. Bidirectional dialogue, again, continuing to talk with people is really important. All right, yield and close the loop. This is kind of where MDRs comes in, is we get a feel for things. We get a feel for our PT and OT note. We go into MDRs and we say, hey, Jeremy came in here. He had sepsis secondary to a UTI. He had a kidney stone, urology came in, cleaned it. We're ready to get out. We're ready to go on some antibiotics, but PT is an older guy. PT is recommending skilled nursing facility. Your case manager will look at you and say, okay, can you consult me to place that patient into an SNF? And you'll say, sure. And then you leave and you go discuss it with your senior and your senior will show you. Again, it's doing all these things early really helps the patient who is now stable. He's doing great. Get him to his next destination safely. Okay, so again, very important here at this end here. All right, so each in front of you will have this MDR's checklist that I made. This is something just to go over and get a good feel for. You have so many things that you're balancing right now from a medical side. You're learning guidelines, you're learning antibiotics, you're learning who to talk to, you're learning what's scary and what's not scary, and you're learning all these things. It helps that when you go into MDRs, you kind of just don't walk up there and stand still and don't really know what to say, because we've all been there. It helps with knowing the few things that you need to check off so that you can get in and out with each patient in maybe 3 minutes, and then you're on back to rounding and then eating lunch here and hanging out. So MDRs, knowing what to say, knowing how to go through it is going to be really important using this checklist here. So the first thing we talk about is medical. Is the patient stable for discharge? So I know we can't see as well here, so you can look at it in front of you, but we kind of talked about those things. You'll get a better feel for it the more you are on floors and see patients, but some of it is kind of self-explanatory. So patient comes in with COPD exacerbation, they don't require oxygen at home, they're on high flow, or which is, we'll talk about that, but or they're on increasing oxygen requirements, they're so wheezing, they're not going home today. We don't really need to talk about it. What can we do from a medical aspect to get them more optimized while also working on where they're going to go? Because if the patient is wheezing, they're super decompensated, they got other comorbidities, which all our patients do, there's a chance they're going to go somewhere else. Looking early at that physical therapy note and knowing where they're going to go, knowing how to place that order, and then while stabilizing them from a medical perspective, you're kind of killing two birds with one stone, if that makes sense. We're clearing them from a medical side while also working on their discharge location from a social side. So again, just kind of different things to think about. Patient stable, if patient is stable for discharge, let's go kind of down our list here. Let's say they are. Let's say they're a COPD patient, they came in, we did all the proactive treatment, we got them following up with pulmonology. If they're pretty decompensated on the outpatient side, we've got their nebulizers, we've got their inhalers, we've got everything kind of set up for them. They've completed their courses of everything they need to convert. We will then review our IV medications. Is the patient still receiving IV medications? Can we transition them, right? Because if a patient is actively receiving IV medications here, there are caveats, but most of the time we need to transition to oral first or talk about transitioning to oral on the way out the door. So just good things to talk about on our rounds and on our MDRs. If they're converted to PO, talk with your senior, talk with the pharmacy, and we'll kind of move forward from that aspect. Oxygen requirements, we talked about it. Is the patient currently requiring oxygen? Is the patient on their home oxygen dose? If they're on their home oxygen requirement, we don't have to do anything. We can let them go on that oxygen requirement. If yes, is the patient currently on home oxygen requirement? If they are, we talked about it. If not on their home oxygen requirement, or they're still requiring O2, we need to talk with our nurse and we say, hey, they're on 8 liters. I know you're super busy. They're not wheezing anymore. They look great. Let's wean down their oxygen this morning. These are things to talk about when you guys are rounding alone. You'll talk about it again on rounds, but these are like the small things that sometimes pre-rounds feel like you're not doing much. These are the things that are really important that can really make a big difference. Because if you have that one-on-one connection with the nurse, she's got 6 other patients, you come back on rounds and you're with a team and you're firing off all these orders and she totally forgets to wean down the patient, but you had a conversation this morning, say, hey, let's wean them down. You're about to leave. You come back and say, hey, whoever, let's wean them down. And the nurse will then wean them down if they're able to. These are little things that the patient sometimes will just sit on 6 liters unnecessarily, satting 102%, and they're unnecessarily staying here because of just one small thing, right? So good things to talk about. So if the patient is unable to be weaned down, this happens all the time, where we need to send them out on oxygen. How do we do that? Again, I'm just letting you know now, and we're putting it in our MDR checklist, but you'll be able to talk with your senior about this. How do we send them out or know if they need oxygen on discharge? We'll say the patient is ready for discharge. We now need to evaluate if they need home oxygen. Once the discharge order is in, prior to this, you're going to place a 6-minute walk test. So our respiratory therapists or the nurses, it depends on the floor, should be the respiratory therapist, will come up. They'll walk with the patient. They will see what the patient is desatting to when they're walking, and they will determine whether or not they need oxygen at discharge. So when we place it, I told you kind of exactly how to place it here. If the patient is able to get enough home oxygen, failed 6-minute walk test, and then we need to place DME home oxygen orders, your senior will show you how to do that. It's very easy. Once you place it, I love following up with the case management because they're the ones that are ultimately going to get this. It looks like a lot of crazy things on the order. You're going to place what you think they need, and then they'll get back to you and say, hey, this is so wrong. Can you please change it? And you'll say, sure. And then you go back and change it. Or they'll say it looks great. That happens to me all the time, so it's all good. Moving into the non-medical side. So we kind of talked about the medical side. Medical side, big things are going to be IV medications and oxygen. From the non-medical side, PT and OT. Knowing how to look at their note early on in their admission, even though they're not quite medically stable, and figuring out where they're going to go is really important. So if home, we talked about it, no further work needed. If they're recommending low intensity rehab, we're going to place home healthcare orders. If they're recommending that, as soon as you see it, run to your senior and say, hey, I'm going to place home healthcare orders for this patient. I'm going to look really good on rounds when they say, hey, has PT seen it? And I say, yeah, I placed the order yesterday. They're recommending low intensity rehab. Home healthcare was placed this morning. Trust me, it makes you look awesome. If they're recommending moderate intensity rehab, we're going to consult case management for SNF placement. It's just like placing any other consult. Please grab your senior about it. Consult case management, SNF placement. They will then do the rest. Just super nice. High intensity rehab. Last thing, we have an inpatient rehab team here, a PM&R team. You are going to place a consult. Again, you don't have to remember this right now. It's on your checklist. Your senior will be able to tell you to Dr. Leary. Dr. Leary is our PM&R doctor. He will send either him or one of the residents working with him or his MP or PA down to evaluate the patient to see if they'd be a good fit. Doing this early, even though the patient isn't quite medically stable for discharge, will save you time on the back end, because you have patients waiting here for crazy insurance stuff. And then it's a holiday weekend, and then 7 more days go by, and the patient is stable, and now they're unstable because of whatever happened. Then you have to cancel the discharge and repeat the whole thing over again. And trust me, it's a huge headache. So getting this stuff done early so that as soon as the patient is stable, they're able to go and get the appropriate rehab is super important. So that's it from the PT and OT side. From the DME side, you're able to just scan the note and look at DME. As soon as you see something that they're going to need, even if they're not quite ready yet, you place it. The case managers will work on it. They'll bring the walker or the cane or whatever it is to bedside upon discharge and get that going. The last thing you want is you got the patient stable. It's 5 p.m. You left for the day. And at sign out, somebody is saying, hey, this patient can't go yet. Their front wheel walker isn't here. You got to find your computer home. You got to call whoever's in the hospital. It's a mess. So doing it early is super important. Follow-ups. One of the big things we do as primary is upon discharge, med-rec status and follow-ups in the outpatient setting. A lot of times for our patients, we are the bridge to getting them good care and surveillance when they leave here. It is so easy to miss those things and just kind of punt it to primary, and their primary has 10-minute slots or they don't even follow up with their primary, and the patients fall through the cracks. So getting early follow-ups when recommended is super important in the hospital, even if they aren't cleared for discharge yet. Your senior will show you how to do that. But let's say a patient has a new incidental finding of a pulmonary nodule. We are going to send them to pulmonology in the outpatient setting. Using our future orders tab on Epic, which your senior will show you how to do, you can place referrals to pulmonology that then our special team, our Care 360 team, which we don't even have to consult anymore, they will just come and set it up for you, will then follow up and schedule that appointment with them. But they won't do that unless we place the order for the outpatient referral. So these are things that the COPD patient that's been here 6 times in 6 months finally has good oversight with pulmonology, or even a good PCP here downstairs will get them the right nebulizer, get them the right treatment, and prevent them from coming back to the hospital. So it's just little things that as an intern, you're so bogged down with the medical side, which I completely understand, but it's just little things to think about so that 6 months down the road, you don't say, oh, this patient ended up never following up. I discharged him. I was supposed to send him out on pulmonology. He didn't get it, and now he's back. You'll see that anyway, even if you do everything right. But this is just making sure you're kind of covering all your bases from that side. All right, I'll promise you I'll wrap it up quick here. But from a medical side, we kind of went back. Non-medical. Okay, D means follow-up. All right, key takeaways. Early discharge planning. Again, these are things that you get a feel for the longer you're an intern. But just to start thinking like a senior, I promise you will pay off dividends in the long run. Proactivity or reactivity, reaching out to people and messaging them personally, I promise you it'll pay off. showing up to MDRs with things to talk about. So, hey, I saw that PT recommending moderate intensity rehab. I placed the consult to case management with my senior last night, follow up the next day and say, hey, have we sent them a list yet for the SNFs? And the case manager will be like, no, actually, I have 15 other patients. And you'll say, can we do that today? And they'll say, sure, because they wouldn't have otherwise. So it's just little things that you get a good feel for, where we're teaching you how to kind of think like seniors early on so that something will stick and we'll like know what to say when we're at MDRs. I promise you it helps in the long run. Effective multidisciplinary rounds. Again, MDRs are helpful if we make them, right? That's kind of how my view is. Use the people there. You'll get a good feel for them. A tip is just knowing names early is really nice. So knowing names, making personal connections. If we form connections with our charge nurses, with our pharmacists, and really with our case managers, they will know you and they'll say, hey, Jack asked me to do this. The patient isn't discharged yet, but I know that he's going to ask me about it tomorrow because Dr. Santos is breathing down his neck to get this patient out of here. We want to do it now. And so they'll do it, okay? This is important stuff that I kind of get a good feel for. All right, that was a lot. You're doing all the medical stuff right now. This is just something from the other side just to think about and have open dialogue with your seniors. Do we have any questions? Yes.
Ambulatory referrals.
Yeah.
Make the PCM appointments.
Yeah.
Because of how the system works, it still has to be for the clinic under my.
Got it. Okay, cool. Yeah. So
Care 360 automatically schedules them on the TCM schedule.
that's a good point. So we have so many patients that don't have PCPs. A decent amount of them have been to the hospital enough where they are ready to get care and they're ready to seek care. And we have our office right here. They know where it is. They know how to get here. They know you. Sometimes they'll see you on floors and want to see you in person. It's really great. When we're ready to send them out on a primary care with an internal medicine follow-up, make sure we're using Dr. Hadid's name for ambulatory referral to internal medicine. Use Hadid. If you just type in HADID, they'll send them that, and your senior will know that as well. Okay. Any other questions? Yes.
So what's the indication for PT or T? Like, what's the threshold?
Yeah.
What do we talk for?
Great question. Most of our patients here will need a PT and OT follow-up. It's actually more so rare that they aren't being seen by PT and OT. Anybody that you'll get a good feel for it, but it's going to be our healthy 30 or 40-year-old male or female with no comorbidities who's never been in the hospital. But even then, I'd probably still get a PT and OT eval. So talk about it with your senior, talk about it with your attending. When in doubt, it doesn't hurt to put a PT and OT follow-up through. Also, yes. Okay. Yeah, that's fair. That's fair. Understood. Yeah. Yeah.
The guy, you think, I haven't really seen him getting out of bed, walking,
Yeah.
you know, and they're weak or they say they're a bit dizzy.
Yeah.
Then I would do it.
Sure.
Not
No, that's completely fair. Completely fair.
Rule of thumb, most of the time it's going to be related to patients that already have some certain limitations. Geriatric patients, for example, they come from facilities, they come from home, they're on the care. So these elderly patients with multiple comorbidities, for sure, you require a PT/OT evaluation. Young patient that came here for trauma, was in his bike, he fell, he broke his finger, had a cellulitis around that, came here. Obviously, that's a patient that is independent of his ADLs and IADLs. So remember, that's the key point here. PT/OT evaluates for the patient's capacity to do ADLs and IADLs. So the patient characteristic is going to dictate if he's going to require or not. Most of the time as well, the nurses can do bedside assessments, and they also can give you a hint and say, hey, Dr. Santos, Dr. X, this patient, I think, is having some difficulties transferring from the bed to the chair and going to the bathroom. So automatically PT/OT evaluation. But I'm doing your admission, you're going to be able to smell it. 75-year-old guy, he's sure hypertension, lipidemia, COPD, on oxygen, he came home from with shortness of breath, COPD exacerbation. Immediately, you need to put PT/OT evaluation in the ER.
You'll get a good feel for it. Yeah.
patient baseline, okay, before he was admitted to the hospital and his like activity is the same, so no indication for PTOT evaluation. But if the patient's baseline not the best, do we still need work on to
Oh, yeah.
improve him?
Yeah. And then if you have your patients like they can walk in by themselves and after 1 week in the hospital, they cannot walk by themselves because they've been in bed for so long. Let's say those patients with COPD because they're radiation on BiPAP, but they get very, very weak here. You could PTOT early, so you don't wait until they get to the point where they cannot even walk. So you try to keep them stable. So patients who can hold, for example, you have to address with PTOT what is going to be the need. Patients who can for this generalized weakness of mom is not doing fine at home or dad is not eating okay, and I can see that now he has failure to thrive. That's how we call it. So those patients need to get PTOT so we know what they're going to need when they go back either home or if they even have to go to a skilled nursing facility for a little bit. So what Dr. Santos and Dr. KB were saying is like totally common sense. Like if you see your patients camp with previous weakness, like failure to thrive, falls, if you see the patient is not able to walk anymore, those patients need PTOT before they move forward. If you send them home like that, they're gonna come back right away.
So going to your baseline versus no baseline. So if a patient you have is certain baseline status, these have short hospitalization, there was no major issues, so no problem. PTOT evaluation may not be needed. But if a patient at baseline, you know his baseline, but you anticipate is going to spend several days in the hospital, then be proactive, get PTOT since the beginning, so you can keep it at baseline and not stay several days in the hospital, and then he can develop a weakness here just for being 3 or 4 days in the bed. You get me?
Yeah.
All right, perfect.
Because a lot of times when they're working with physical therapy is like one of the only times they'll be supervised walking around the unit. And other
Correct.
times they'll just be sitting there watching TV and you'll just see them decompensate.
So what do you think about patients with a stroke? You don't wait until the patient is medically stable. Those patients, because we're a stroke center, you have to do PTOT on admission. It's part of the stroke protocol. So you think about TIA stroke, PTOT evaluations right there.
The only way we get the patients walking around the unit is through PTOT. It's not an order for nursing, like
They can do it.
could do it when we're talking to them in the morning and walk around with them, or.
They can do it with the nurse.
Okay.
Yeah,
So we could put an order for the nurses to like each one of the patients.
yeah,
Yes.
absolutely.
Okay.
Important. Yeah, very, very good.
And the nurses themselves, I've had to tell you guys, they are your partners.
Mhm.
They've been doing, most of them, they have experience and they're going to have a feel of the patient. As soon as they're trying to lift them off the bed or get him from the chair, say, there is something the patient is requiring probably more than what they can assist. They will call and say, I think this patient needs PTOT because he's having issues with transfer. So follow up on those things.
Yeah, I just wanted to go off of that, put you guys to the nurses and all the staff. I think that early on, as much as you guys can, be friends with the nurses, the care management, and everybody else. And if you guys know me, you know that I'm friends with all of them. So you know that's gonna come in handy very well for you guys. Because trust me, they can make your life very good or not if you're not nice to them. So all I'm saying is that try to be as nice as you can because they are your biggest asset in here, and they will help you tremendously. It's a lot of things that we don't learn in medical school that you learn in here. Like Dr. Haffey saying a lot of things about placing some specific orders. We don't learn that in medical school. You might be the brightest person ever, but if you don't know how to communicate with your nurses, if you don't know how the process works, you're not going to do well. So, knowing how to operate in that and the logistics will determine between being a great physician and not being one. So that's very handy.
Completely agree. Yeah. Any other questions, guys?
I was gonna say one thing.
Yeah.
I know there's categorical TY in here, and so everyone maybe if you're IM, you want to do cardiology, and so MDRs may be more or less interesting to you all, depending on what you want to do. But I try to think of it as if you just erase MDR, just let's not use terminology. We can all agree that communicating with staff, involved in our patients, talking about barriers and treating the patient as a whole. I mean, that's one of Advent's like mottos, right? And marketing thing is treating the patient as a whole. That's what MDRs are. So that transcends DY and categorical, and these are professional skills that are going to help you develop and be really well. So and if you're thinking about it now and worried about it, you're way ahead than I was. This was not crossing my mind in residency, but it's really good for professional development. And like I said in the expectation lecture, we know that over 80% of medical errors are from miscommunication. So now we have the opportunity to do something to minimize all of this. You're protecting yourself, you're protecting the patient, and so it's a really good skill.
Yeah. Residency is hard. Do things that make your life easier, and I promise you, doing MDRs well will make your life easier, no matter what your outlook is on it. Yeah.
What if the patient is homeless? Work with case manager regarding that?
Yeah, absolutely. We deal with this a lot. Homelessness is something that is not unique to Tampa in this area, obviously in the US, but it's something we deal with a lot in this specific area of Tampa. There are specific shelters and specific discharge locations that your case manager will work with. That's why it's really important when you're getting an admit, when you're getting an overnight, and you're seeing the patient for the first time, as you're covering through everything. You're covering why they're here, you're covering family history, you're covering social history, you're talking about the medications they're on. Always finish with, hey, where are we living right now? And they'll tell you. And sometimes they'll say, hey, I'm currently out on the street, or hey, I'm moving from couch to couch. It's something early on that you know about that then we can act with. So then, as you're going to MDRs, you talk with the case management and say, hey, I think we have some home insecurity here. What can we start working on now in order to get this helped and solved by the time discharge is ready to come around? And then something you talk with the patient about as well. And you say, hey, have you been to Salvation Army? Have you been to this shelter? Do you have any opinions on where you would like us to go when you discharge? Okay, again, it's a two-way street with the patient, and it's a two-way communication with the case manager as well. Yeah.
Different. So like you say, paging the CT surgeon at 5:30 in the morning, if you feel like it's important, if you feel like you know, it's an aspect that you're not confident in waking them up. He got back to me. Don't do that. But I think you're proactive with your thing. There's something that you frequently address. Reach out to the consultant, come up with a plan before you round, and that will make you look so much better knowing, hey, I already reached out. It looks so much better when you go to rounds and like, hey, Dr. Sanz, I already reach out to the GI doctor, and if he has cleared the patient is good to go. He's gonna go to home health and already place the order. Trust me, that will make you look so much better, and that means you're just being proactive, and it makes a big difference on the ground.
Another question. So we also see other people that you mentioned, right? Like pharmacy and stuff. Like, what would be a conversation that you like should have with them if you have any questions?
Yeah.
CCare 360 people, they're like,
Yeah.
Put some insight.
Yeah, absolutely. Pharmacy is awesome. Pharmacy, each of them are on the floors. They'll message you from the pharmacy itself when they're ready to send medications out. Pharmacy is really good if you have any questions on medication adverse interactions, on contraindications, and on switching from IV to PO. It's really good to have kind of an open dialogue. I am always into the idea of constantly asking questions and never being afraid to look dumb or being afraid to look. It's so easy just to nod your head yes when someone tells you something and you have no idea what they're saying. It's a lot harder to be like, what do you mean by that? Or, hey, what is that? And they'll explain it to you. And instead of going away and not knowing what they talked about, you now know what they talked about and you're ready to teach the person next to you, or you'll know for the next time. So having that two-way conversation early about adverse events or adverse interactions, contraindications, and then when to switch and how to switch is good as well. So pharmacy important as well. Yeah.
So they're gonna approach you and they're gonna say, hey, Dr. Haffey, I noticed that we have ordered this medication, but I looked into it and the medication was stopped 3 months ago. Do you still want to continue with that medication while the patient is here? So that's a great opportunity to clarify that. Maybe we are doing the MedRec really quick. We just go by what we got during admission. That's not a verified MedRec, but they do it. So during NDRs, you have the opportunity to do that. They go into the past admissions, they go and check on the pharmacy dispense history, and they go and talk to the patients. And they can tell you if you want to change your medical management based on that. So that's a great opportunity during NDRs.
For a patient that doesn't have insurance and doesn't have access necessarily to insulin or certain medications, do we direct that through case manager, through pharmacy, or through both?
The answer is yes. Yes to everyone.
No. Yeah, but that's exactly, the whole team is there precisely for those issues. So any particular issue you may have, the right person in the team will assess it. For example, medications that you're saying, you're gonna find these patients no insurance, that the hospital probably is gonna assist them with medications. Care 360 will help you over that. So they're gonna try to set you up for the pharmacy downstairs at Walgreens and give the patients bedside medications through them. So Care 360 will help you out. Just in front of the team, as long as you explain your problem, we're gonna figure out in the team who is responsible for that particular issue. But sometimes we don't have all the answers, right?
Yep.
And even themselves, they say, hey, X, can you take care of this? And they say, yes, this is within the scope of the things I do. Somebody was talking about homelessness. Okay, the homelessness situation is everywhere, as Jack was saying. Here's a particular situations that the most common things you're gonna find with homelessness. Homeless people that may require home health care services. So if you're gonna get home health care services, we don't have a home. So the hospital has an agreement with shelters in the community, specifically Salvation Army, and they have certain amount of beds assigned to the hospital. So we can send the patient to the shelter, and the patient can get, for example, a certain amount of days of home health care in that particular shelter. That specifically comes along with people, for example, old guy, homeless, that had a hip fracture. So we did the surgery, we fixed him, but he's not gonna be able to go to a rehab facility because he doesn't have the resources. So we go and send him to the shelter, and then we do home health care in the shelter. That's a possibility. Another thing is, these patients have a lot of medical issues and are homeless and always admitted to the hospital. The case manager can do referrals to case managers, social workers in the community, so they can follow up on that patient and see if they qualify for any sort of help from the state, Medicaid, or housing assistance. So they can link them with those social workers in the community. So again, case manager and social workers can do a lot with those patients too.
All right, guys, any further questions? Just a few quotes here. I know we're starting early, but something I love from Arthur Ashe: start where you are, use what you have, do what you can. I know it feels like sometimes on rounds we have no idea what's going on early, and it's completely okay. But start where you are, continue to build every single day. If you just, trust me, it's corny, but I'm a former athlete. 1% better each day, you will build, and you will build up fast. So it's okay if you feel like you don't belong. It's okay if you don't feel like you don't know anything. We all started here. You're only going to get better, I promise you. Lastly, fortitude is the fire that turns adversity into wisdom. I promise you, you'll have long hours, you'll have long days, you'll have easy days, but you'll have times where you feel like this is really hard. No one ever got through better on the other side by just taking things easy. The hard days, the questioning times, the problems where you feel like you can't solve them, when we do solve them on the other side, the next time you face them, it'll be twice as easy. So I promise you it gets better. Keep your head down, keep crushing it, and we're going to have a good year. Okay, guys?